The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, or good evening, depending on where you're joining us from. This is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we're really excited to be hosting this webinar. We'll be getting started in about 10 minutes, but I just wanted to check in so that everybody knows that we do have the platform open, and I'll check in again in a couple minutes as more people join. Hello, everybody who's just joined us. Again, this is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we'll get started in just a couple minutes, and I'll give a quick welcome once we have more people on the line. Hello again, everybody. Again, this is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we're going to give it just another minute. We have a lot of people on the line, but I know a few more are planning to join. So we'll get started just a minute or two after the hour. Thanks so much. Okay, good morning, good afternoon, or good evening, everybody, depending on where you're joining us from. One more time, this is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we're really excited to be hosting this webinar through the new and underutilized Reproductive Health Technologies Caucus. Just a quick moment of housekeeping. All attendees are in listen-only mode, so you're automatically muted to prevent background noise. Over the course of the webinar, as questions arise, I encourage you to please submit those through the questions feature on this webinar platform, and we'll hold the Q&A at the end of the webinar, and we'll try to get to as many questions as possible. If you're having any technical challenges, please feel free to write into the chat, and we'll do our best to address those. With that, I will turn it over to Heather to get us started.
Thank you, Sophia, and good morning, everyone. Over the next 60 minutes or so, we'd like to give you an overview of a project that our team conducted primarily in 2017 that was funded by the Bill and Melinda Gates Foundation with the aim of re-envisioning the future of women's contraception. So over the course of this presentation, you'll be hearing from the 5 speakers you see here, and I'll let each person give themselves a little introduction as they move into their section. But I'm Heather Vedat, and I'm the Associate Director of the Contraceptive Technology and Innovation Department at FHI 360. So, as many of you may know from either personal or professional experience, numerous methods of contraception exist. You may also know that few, if any, methods are highly endorsed by those who use them. In fact, most products are tolerated at best. This is likely because few products were initially developed with input from users. So for this project, we aim to flip the development process by asking, can we start with the end user in mind? To do this, we leveraged a human-centered design, or HCD approach, that engages a multidisciplinary group of stakeholders comprised of designers, potential users, product developers, and researchers to ideate and generate out-of-the-box solutions around a central problem, in this case, of course, developing more user-friendly contraception. So as a bit of background for the why for this project, nearly 1 in 10 women globally have an unmet need for contraception, meaning that they are of reproductive age and are not using a modern contraceptive method, despite having the desire to delay or limit future childbearing. The level of unmet need varies with, for example, about 14% of women in South Asia and 24% of women in Africa falling into this category. There are many barriers to contraceptive use, ranging from lack of access to methods, lack of access to trained professionals for removal services if applicable, and of course the side effects such as bleeding disturbances, weight gain, and other issues. So why did we adopt an HCD approach? Well, we were able to observe that HCD has proven to be a successful approach in other product areas as a means of fostering disruptive thinking, which was very appealing to us. And the HCD approach explicitly calls for identifying user needs for gaining insights into what is driving them with respect to contraceptive need. It also focuses on the inclusion of a diverse set of experts that can bring a fresh eye to the challenge and extrapolate ideas based on their experiences in their respective fields. The HCD approach is also flexible and includes a vast toolbox of methods that can be utilized to generate and stimulate ideas and solutions. We were particularly interested in developing concepts for new contraceptive technologies that met the needs of women in low-resource settings, recognizing that sociocultural and health systems contexts that influence contraceptive use vary widely. We aligned on Kenya and India as the 2 locations for our work, and while both countries have relatively high levels of contraceptive use, their method mix varies quite dramatically. As you can see here, there are several methods that are divergent between the 2 countries. For example, sterilization is 39% in India versus 3% in Kenya, while injectable use is less than 1% in India compared to 28% in Kenya. Implants are not available in India, but account for over 10% of method use in Kenya. Overall, there's also just a wider range of methods that are available to Kenyan women. So with that, I am going to hand over the presentation to my colleague, Babita George, who will talk to you about how we built our HCD strategy. Babita?
Thank you, Heather. My name is Babita, and I'm a partner at Quicksand. We're a human-centered design firm based in India. Over the next few minutes, we'll take you through how we went through the HCD process in the course of this project, going from research to the workshops that we ran in both countries, and thus generating ideas for future contraception. Next slide, please. To give you a quick overview of who we met in both countries, the women as the core users were at the center of our inquiries, but in understanding the woman's needs, we tried to understand current contraceptive behaviors and practices, as well as larger attitudes and perceptions around sex, birth control, reproductive health, larger attitudes towards family planning. But in addition to the women, we also wanted to understand the larger domestic ecosystem and support structures that women have, as well as the contraceptive and healthcare ecosystem. Thus, in both countries, we worked with several NGOs to identify women aged 16 or older who had experience using contraception. We also talked with husbands and partners, as well as healthcare providers, chemists, religious leaders, as well as policymakers located in each country to understand how these social and cultural contexts impact contraceptive use. Next slide, please. This gives you an overview of the locations that we went to in both Kenya and India. Across the two countries, a goal was to explore a diverse range of perspectives, from people living in large urban settings and their peripheries like Nairobi, New Delhi, and Calcutta, as well as smaller towns. We wanted to get a range of contexts across factors such as city size, development stages, different sorts of occupations, access to healthcare, and cultural practices. Next slide, please. So the research team that conducted research in the two countries were divided into three. The teams consisted of researchers and designers from both FHI 360 as well as Quicksand and an independent partner, Pabla Van Heck. In both countries, we also teamed up with local guides. They served as translators, but also as very crucial cultural guides. This slide gives you an overview of the various research formats that were used in our interactions with women and other stakeholders. This ranged from one-on-one discussions with women about their experiences, group discussions on contraceptive use and ideal products, context visits to various settings to understand how these women live, work, access health and family planning services, as well as intercepts and brief interactions with members of the community to get a sense of the larger cultural norms and practices. Overall, we spoke to more than 300 women, partners, and other stakeholders across the two countries. Next slide, please. This slide is a quick overview of a day in the field for one of the teams that was meeting young women. So the day consisted of in-depth interviews with girls as well as other stakeholders like their parents, school principals, teachers, people who had an influence on their perceptions and use. We also conducted intercepts in the neighborhood with pharmacists, shop vendors, and other areas that the girls might spend time in. We also ran focus groups with these girls after school. There were a range of tools that were used in the course of research, and after research, every day the teams met separately to synthesize what they had learned over the course of the day. And at the end, the three teams met to kind of begin to understand what were the larger learnings that we had from the field. Next slide, please. This slide is a quick overview of the 8 thematic areas that our insights and learnings fell into. Later in the webinar, you'll get to see how some of these insights really helped us provide the prompts for ideation during the workshops, as well as formed the basis for the design considerations that we developed. Next slide, please. In addition to analyzing the data to identify these key themes and relevant insights, we also considered how the women that we met fit along a reproductive journey from menstruation to menopause. You will see some key milestones along this journey. There are several others. We've called out a few of them. You will also notice 4 colors along this journey. These colors represent 4 phases. starting from discovering, which is the first phase where a girl is having her first period, is encountering sex, beginning to get more familiar with relationships, her own body. The second phase is that of adjusting, where a woman is beginning to relate to others through a relationship, marriage, and often their first child. The third phase is that of balancing, where women are really balancing the requirements of their partner, children, household requirements, as well as work. And in the final phase, which is continuing after the children have grown up, the burden of the family has lessened and she's beginning to focus on some of her own needs. Next slide, please. Keeping in mind our goal to develop new contraceptive products that were really responsive to women's needs, we tried to develop user profiles based on composite information from the women that we met during research. These profiles were really developed qualitatively and do not represent an exhaustive typology, but were meant to provide rich inspiration to our ideators who needed to keep in mind that different women might need different forms of contraception. The same product cannot fit the needs of all women. Some of these profiles are unique to either Kenya or India, but most of them represent types of women found in both countries. When developing these profiles, some of the things that we considered were women's level of personal agency, the types of relationships that she had with her partners, family members, and the larger community, as well as the kind of access that she had to work, to finances, as well as to family planning services. On that note, I'm going to hand over to Neha.
Next slide, please. Hi, my name is Neha, and I'm a partner along with Babita in Quicksand. So I will talk you through the ideation workshops. We conducted these ideation workshops in both countries, Kenya and India, after the phase of research. The aim of these workshops was threefold. One, it was to come up with new and disruptive ideas in contraceptive technologies for women. Two, it was to emphasize the value of human-centered design to the field of contraception. And finally, it was to encourage cross-pollination across diverse fields. So all of the research material that got generated in the previous phases, we brought that into these ideation workshops in the form of collaterals that brought to life the user's context in these settings. This effort to keep the voice of the user present and prominent in the room allowed for all the ideas to be tempered against these women's realities. Next slide, please. In each of these countries, we conducted a 4-day ideation workshop, which was attended by approximately 50 to 60 ideators. These ideators represented a wide range of professional backgrounds and drew not only from Kenya and India, but also from the global and the international setting. The invitees included scientists and product development experts, clinicians, social science experts, reproductive health advocates, designers, amongst others. Next slide, please. So these workshops were highly participatory and were designed to lead the ideators through a series of complementary phases so that in the course of this workshop, an ideator would become increasingly familiar with the realities of women that we met, and then finally be able to design and develop and refine ideas for new contraceptive technologies as responses to women's needs. So on day one, what we did was that we broke up the participants into smaller groups with a mix of local as well as international participants in each of these groups. And we went out into the context. We went to clinics, we went to NGOs, we also went to markets, and finally we also went to a lot of places of work. And these were all around the ideation venue. The idea here was to give the ideators a first-hand experience of women's day-to-day lives. What was interesting was that when we had a feedback session later during the day, we learned that even an immersive session like this proved to be foundational and valuable even for our local participants. On the right, what you see are these zines. We created these zines as takeaways for each of the workshops. workshops. Now, they were meant to bring together stories and anecdotes from the field, communication around family planning, advertising, as well as other relevant snippets of cultural information. All of it was packaged in a light way and was meant to complement the research findings. Next slide, please. On day 2, the participants were exposed to the findings of the foundational research. This took the form of a range of formats. We created videos, we also had posters, cards, as well as decks that were extremely visual. All of these collaterals highlighted the user's needs, their context, their challenges. We designed different breakout sessions where small groups would learn more about user profiles, their personal lives, their aspirations and behaviors, as well as their experiences with contraception. And the group sessions were encouraged the participants were then encouraged to identify the key challenges and then brainstorm potential approaches to address them. What you're looking at on the left is something called a challenge card, and we created these where we captured key challenges faced by users that we had met across the field research. And on the right-hand side, you see these user profiles, and these were created as a synthesis of the women we had met, something Babita mentioned earlier, and we used these in parallel with the challenge cards, where they were meant to shed light on the women that we had, their environments, their aspiration hurdles, and again, their experiences with contraception. Next slide, please. So in phase 3, which was also day 3, we invited participants to think out of the box during several exercises in which they imagined these worlds of the future. So what we did was that in order to get them to think about these moonshot and future-facing ideas, we organized a headline framing activity during which the participants wrote down these headlines that they imagined could exist in a world in the future, and then they placed them on a timeline which ranged from present to the far future. The idea with this then was that the participants were tasked with choosing a few of these headlines, and they had to use that to come up with a contraceptive idea that existed in this world, which was defined by those headlines. This is what you see on the right-hand side. This exercise resulted in a range of ideas that were not only innovative and, quick and rough, but they provided a base for further refining and inspiration for the final ideation rounds. Next slide, please. Finally, the participants worked in smaller groups to generate and present CTA ideas. We use 2 formats to help facilitate and guide this idea generation. What you're looking at on the left is a more concise format which was introduced earlier to help structure the thought process, wherein a participant was meant to write the value proposition behind an idea. The second template was a more detailed format of, where the idea could be detailed in terms of the mechanism, the format, which user it was meant for. Finally, once we had all of these ideas, the full group and the ideators voted on these ideas. The ideas were primarily voted on A, the ability to increase uptake amongst our users, and B, to improve the current user experience. And a subset of these ideas was finally sketched, and it was refined, which you see on the right-hand-most side. And then they were tested with some of the women and their partners and other stakeholders who were present during these workshops because they were from the nearby context or from our previous field research phase. With that, we end the workshop section, and I'd like to hand it off to my colleague, Betsy.
Next slide, please. Thank you, Neha. So my name is Betsy Tolley. I'm the Director of Behavioral, Epidemiological, and Clinical Sciences Group at FHI 360. This slide summarizes the first part of our webinar. So our goal was to engage through our research phase with a broad range of women in multiple contexts to understand the reproductive and broader goals, as well as their unmet needs for contraception, and then to distill these needs into design principles that are further shared during our ideation workshops, and then through those ideation workshops and beyond to develop products that meet the needs of women and couples. Now we'd like to present, so in the remainder of this webinar, we'd like to present 2 different case studies that illustrate how we went from the research insights that related to our user profiles in order to identify specific contraceptive considerations. And finally, to generate these concepts that Neha kind of gave you a glimpse of for new future forward contraceptive technologies. Next slide. In all, we identified technologies responding to 8 different design considerations. We'll be presenting just 2 of those. The first one we've labeled power to the user. Next slide. In both countries, participants described ways that social norms were shifting. In Kenya, many of the women we met appeared to bear the burden of managing their families alone. In India, it was all about the extended family, so many of the women we met were living with extended family members, but even then, younger women and their partners indicated that they wished for, and they talked about ways they sought to have more autonomy in planning and managing their families. One of the insights that we came up with as we were doing our research was the importance of discretion. So discretion in matters of contraception were important in both settings, but for very different reasons. In Kenya, because contraception seemed to be regarded as a private matter, and sometimes something that was limited to the woman herself, they talked about preferring methods such as the injectable that could be used without partners or families finding out. Conversely, in India, because contraception is not a private matter, women desired methods that enabled them to keep some kind of control over their choice and use. So it was often within their relationship with their partner that they would try to make some of these decisions. According to a chemist in Delhi, it's usually men who come to buy pills for their wives. They won't even know the names, but they'll carry the previous packet with them to show which one they want. Next slide. Another insight had to do with providers. Providers' perceptions and biases can impact the access and method choice for women across different reproductive stages. In India, stigma around premarital sex as a barrier, acted as a barrier for unmarried women to access contraception. This was especially true in public health clinics. Conversely, in Kenya, the group that met with adolescents talked about adolescents calling out their counseling, calling out the act of being over-counseled or being asked too many questions about their sexual relationships. And for that reason, they often preferred visiting chemists over youth clinics, even though the latter provided free of charge products and services. Even community health workers who stocked oral contraceptives are only allowed to give it to clients once they have obtained a prescription from a local clinic. For that reason, girls would resort to using emergency contraception when they had sex, which was sometimes bought by boyfriends from a private clinic. It was surprising. I was in the older women's team, and even there were barriers to contraceptive access for older married women. In Kenya, older women felt embarrassed or self-conscious to go to public clinics or chemists, as they didn't want people to know that they were still sexually active. So one nurse that we spoke with at a private clinic in Nakuru said, if an older client comes to the clinic, I'll make sure to seat her in a separate section so that she won't be embarrassed sitting in a room full of young girls. Next slide. I think it's this slide. So, even though multiple products are available, women face a lack of options when it comes to finding a contraceptive method which combines their preferred delivery mechanism and duration. For example, although longer-acting methods like implants and injectables provide more reliable protection from pregnancy, women worried about their ability to opt out of a method if they experience side effects, as well as how long it might take after stopping the method to get pregnant again. A method like oral pills that could be stopped easily in case of side effects were often deemed unreliable and prone to accidents. In Kenya, we met women who would cycle through 3, 4, and even more methods over their reproductive lives as they rebounded from an unplanned pregnancy while using pills or the calendar method, discontinued injectables due to side effects, and eventually adopted more invasive methods such as IUDs. In India, many of the women we met didn't use a contraceptive method at all until they chose to get sterilized after having perhaps even one too many children. They chose sterilization over other methods and tolerated the pain and discomfort of the procedure so that they could be tension-free. They were seen as providing reliable and permanent contraception and didn't require experimenting with long-acting, reversible, but kind of medical methods, or methods that were associated with a lot of different side effects. In that way, trade-offs were worthwhile to limit fertility reliably and without this sort of medication. Next slide. Earlier, I believe Babita mentioned the use or the development of user profiles that emerged from our research. One of the profiles that aligns with our power to the user principle is entitled the Empowered Hustler. In this profile, and it was not unique to Kenya, but perhaps a bit more aligned with our Kenya research, the Empowered Hustler is younger, empowered to make her own decisions. For her, the idea of sort of settling down means no more fun or it's too much responsibility. Given her age and unmarried status, however, she may confront difficulties obtaining contraception, especially from the public sector. So she may choose to go to a youth-friendly clinic or purchase something through a chemist. Next slide.